So the question is about looking at the differences between late onset and early onset, and whether there are factors that are causing it to happen later in life.
Yes.
Is that? So that's what we're searching for. So individuals that are born, individuals that have, say, a C9orf72 mutation or a SOD1 mutation, they are born with these. So they have them from birth, but we're not seeing any clinical symptoms for 75 years in some of these patients. We also have patients who are actually in their 90s that have gene mutations that do not have disease yet. So what we're particularly looking for are the factors that are in, say, in older people that don't have disease yet but we know have a gene mutation. Are there factors that are protecting them? Or in, say, early onset individuals, are there factors that are setting off disease? So without looking at individuals that have a mutation over a long period of time, which is what NIM is doing, you need to be able to look at individuals before disease if you want to find triggers for disease.
Yeah. I didn't express myself too well.
Okay.
What I was trying to get to was that, do you have any information which might suggest that, in my case, for example, I'm 81, I've just got it.
Okay.
Would there have been any tests other than the gene test to say, well, you are likely to or not likely to?
Sorry.
So then we've stopped it.
So the question was, are there any tests to identify, I guess, factors that precede late onset motor neuron disease? Not to our knowledge yet. That's what we're trying to find. We're trying to find that from a genetics perspective. So in absence of without being able to find something, we can't say whether we could prevent it. And I think, Nim, you might be able to shed some light on this, and because from what I understand of your studies, you're looking at what's preceding onset of disease. And I know we would ideally, if we can find what's setting off disease, then we could try to stop it or try to prevent it. But it's actually trying to find it, and it's easier in the hereditary form of the disease because we know that they should be getting it. Whereas in sporadics, it's very hard because we don't have any idea who's going to get it in the population. So we're trying to use the familial form of the disease to identify what's setting off motor neuron disease or what's allowing a slowly progressive form of the disease, to then see if we can apply that to sporadic cases.
Down the front.
Thanks, Kelly. With the people who've got SOD1 or C9orf, are you doing the full gene sequencing of them to see if there actually other, so whether the polygenetic stuff could be happening with them as well as with just the less common types of genes?
Yes, so that's actually what I'm doing right at this moment. So no, it's very, very good research plan. Yes, so that's exactly what we're doing. So at the moment we're focusing on the SOD1 cases for the whole genome sequencing, because they generally present with very classical motor neuron disease symptoms. So in a family, you see high penetrance of the disease, which means if people have a mutation, there is a very high chance that they will get the disease. And they don't often present with any frontotemporal dementia at all. So we're using, I guess, a cohort of classic motor neuron disease patients, which we know have a gene mutation, so we can account for that gene mutation as causing the disease, and then we're looking at all their other genetic variability to see if we can look in subsets of patients to see why some may start with bulbar onset or rapid onset.
Have you started to find anything there?
So, well, actually, all of the DNA samples are still at the sequencing provider, so it's literally happening right at this moment. So.
Thank you so much for that talk. I think you made something that's very complicated, very easy to understand.
Thank you.
Easier to understand for people, maybe not very easy. I guess my question is, there's a lot of research being done on familial MND, and it's obviously understandable why, because it's easier to do, because you can actually find the genes that are causing the disease. How can that then help patients with sporadic MND? For example, you know, you find the mutation and then you can use that in animal models. So then how can the findings in that familial form be generalised to patients with sporadic MND?
So that's a really good question, asking how we can use findings from familial MND to actually be applicable in sporadic MND cases. And a lot, as I mentioned at the very start of my talk, the goals of genetic research, yes, they're for diagnostic tests, but that doesn't always help for sporadic cases. But our other goals, which are identifying the underlying disease mechanisms or developing models, these aren't necessarily, we're not necessarily using, say, specific gene mutations to identify disease mechanisms. So, for example, we look at the C9orf72 gene and we want to see what it's actually doing in a cell to see how it's actually causing the cell to dysfunction. And then, so what we actually are finding from that, so we understand more about why these mutations are causing motor neuron disease. And then we see if it's, I guess, because we know sporadic and familial motor neuron disease, they are clinically the same. One just has a family history. So when we're looking for disease mechanisms in families, we know that the same disease mechanisms are actually acting in sporadic cases. So even though we may not be able to have full diagnostic testing for sporadic cases, we can, if we can understand why the disease is being caused and either develop models for drug testing or understanding the disease biology, then the treatments that can come out of that are applicable to all motor neuron disease cases. So.
Thanks, Kathy. Many patients will have one disease mutation. How many patients will have more? And in the sporadic patients, how many have multiple of the less known gene mutations? And does that link with more aggressive progression of the disease?
Okay, so the question was asking if patients can present with one mutation that causes disease, how many patients would present with more than one, and in sporadic, how many patients are presenting with many different gene mutations. So in the 9 years that I've been looking at patients, we have never seen a familial patient with more than one disease mutation in Australia. So we are confident all of our patients, they do get screened for C9orf72 and SOD1. We generally do look for all the other genes as well. And we have never found, so we believe familial ALS is showing this classic inheritance. However, sporadic, it's more likely that they're not specific mutations causing disease. It's more of a combination of them. So there may be, and that's the whole purpose of Project Mine, is to actually look in a phenomenal amount of patients to see, are there certain gene detrimental variation in specific genes that are occurring more commonly in sporadic patients than in controls. So sporadic patient, for example, with our CCNF mutation discovery, we had found mutations in familial cases and also sporadic cases. And in sporadic cases, we looked at, I think 2,000 sporadic cases, and we found there were more detrimental variants, so not necessarily mutations that cause disease, but variants that can contribute to having a bad protein. We found more of those in the CCNF gene, so more detrimental variants in the CCNF gene in sporadic ALS patients compared to controls. So controls may have had a few, but sporadic patients had lots of them. So that's, does that answer? Yeah, okay.
So someone with a mutant gene not necessarily will be diagnosed with motor neurons disease. Is that what I've been hearing?
So in a family, I'll repeat the question. So if a person is in a family and has the gene mutation, sporadic. If a person has an MND gene mutation, will they be able to be diagnosed? Generally, we wouldn't genome sequence normal population individuals. So until that actually becomes a reality of personalised medicine, sporadic individuals are not known to the clinic until they start to develop symptoms. So we can't really offer diagnostic screening unless individuals went and did it themselves before disease onset.
My question following that is, if the familial history is unknown and for a sufferer, should the children or whatever be screened and genomed?
Okay, so the question was, if the family history is unknown, should all of the rest of the family undergo genetic screening? It would depend if we found a mutation in the person with motor neuron disease. So if a DNA sample is available for the affected person, we run through the full screening procedure. So C9orf72, SOD1, we generally do genome sequence and look for all the other gene mutations. And it would only be then that the rest of the family would have to consider screening. They would need to go through genetic counselling first, because as I mentioned, there's so much variability in the disease. So say you may find that your family has a SOD1 mutation, but we can't say whether you will get onset at 20 or onset at 80.
My question sort of follows on from that a little. If the gene has been identified in your family, and besides, I guess, the benefit of not passing it on using IVF, if you have already had your children, what are the benefits of finding out if you're carrying the gene or not?
Well, that is a very personal question, and that's, something we can't answer, and I think that's why patients that do have a family history do go to genetic counsellor even before they find out. So they would go and they would find out the implications of if they have a gene mutation. I guess people, as I said, it's a personal decision. It could impact their future lifestyle choices and jobs, things like that. So.
The patients who could come through with the carriers and the inquiry about testing, if they're going to have children, I think it's an important time to get tested, because you could potentially, with pre-implantation diagnosis, try and stop the gene getting, passed on. But otherwise, it really comes down to a personal situation, Kelly says, because once you have a gene, then that's going to impact on your life insurance, medical insurance, indemnity, and it's going to have vast consequences. So usually, from a clinical perspective, if there is a history, but you're not planning on having children, or you've already had children, I would wait. I would wait until the next generation, then think about having their children. Because then it's at that stage, if as the index case of you're negative, then everyone else below your family tree won't get it. So it's really about finding the right time, and it's very personal. Because once you have a positive diagnosis, you've got to declare it. And then for life insurances, medical indemnity, they can deny you or they can increase your premiums, and it's not worth taking that risk.